Hello, folks. Happy Friday. I'm so sorry for the delay. It's totally my bad. I'm really excited for yet another RLR case today. And I say yet another because it's a lot of familiar faces. It's Leah on scribing, Anmol on teaching, and a returned and long-standing VMR guest and presenter, Zakaria, who is presenting a case today. For the very, very microscopically small chance that folks don't know you, Zakaria, do you want to tell them a little bit about yourself and maybe what you've been up to recently? And then we'll hear from the one and only Prof. Rez for the first aliquot.
Hello, everyone. I'm Zakaria. I've been listening to VMRs and obsessed with them for about 3 years now, well, almost. And I'm currently in Cape Town, South Africa, for those that don't know, doing psychiatry at the moment. As I was telling Maddie earlier, I'm looking for the internal medicine in all of my patients. So there was a discussion about neuroleptic malignant syndrome today, which made the day a bit more interesting. And yeah, otherwise I'm doing well.
Amazing, Zakaria. I'm really curious. What is the psychiatry rotation like? How long are you there for? Is the experience inpatient or outpatient? I'm curious how it's similar or different than what my experience was.
So we did approximately 2.5 months during med school, and then we do another 2 months during internship. And there's a mixture of inpatient and outpatient. So I'm currently at a Soul Psychiatry Hospital in Cape Town. It's actually quite gorgeous. It's on a massive estate with every ward is actually like its own house, and you sort of have to drive between the wards, and it's quite gorgeous actually. Yeah.
Oh, that's incredible. Oh my gosh, it pales in comparison to my psych rotation, which was not at all gorgeous, unfortunately, physically. Yeah, we only had 4 weeks on psychiatry. That's really cool that you get such a deep experience. I now in my line of work, I really wish I had a lot more psychiatry exposure. I think it would have left me better equipped to my current life. But speaking about being equipped, I don't think I'll ever feel equipped to discuss in richness a case that you're presenting. So I'm excited to tag team with Prof. Rez, and we'll hand the mic to you and jump right in.
Wonderful. Okay. This is going to be a very short first aliquot. This was a patient that I saw in my final year of medical school that had left a sort of lasting impression on me. And aliquot one is very short, but it starts off with a 55-year-old male presents to the emergency department reporting excruciatingly painful right knee pain. And I'll stop there.
Zakaria, thank you so much for joining us on another VMR. Just so you know, at 9:30, I'll have to take a break for like just a couple minutes, but Robbie will carry on the discussion. And I love the fact that you've held on to your interesting cases. I think that's a common theme amongst the members of the VMR community, the passion and the love for clinical medicine. This actually is like a very interesting chief concern, because already we're prioritizing an intra-articular process, but we have to temper ourselves because it's very possible that the pathology is actually peri-articular. We have no clues that we're dealing with an extra MSK disease yet. So like the entire focus should just be go and examine the knee. Because when you have excruciating knee pain or any joint pain, my mind automatically translates that into a monoarticular process. And really what I need to be most worried about is there a fracture? Like, was there some kind of trauma? Is there crystalline disease? Or is there an infection? Really, it just comes down, those are like the do not miss causes. And then a do not miss periarticular cause is if you have like a ligament, a tendon, or something that has ruptured. So really, Zakaria, what I would do in this case is just like a rash, where I examine the rash first and I let that drive the questions that I ask the patient. I would just go and examine the knee. And what I would be looking for, is there an effusion or not? I'd ask one simple question, any history of trauma or recent injury to that knee. And then I would touch the knee with the back of my hand. The knee is usually cooler than the other aspects of the extremity. And then I would range it and see if I can range it, because if there's no range of motion, then that really prioritizes some kind of intra-articular disease. Yeah, Mike, to you.
Wonderful. I love how you went through that initial approach. And that's sort of exactly what I was thinking when I saw him. Onto Aliquot 2, he reported that about 2 weeks prior, he had fallen onto his right knee. After that, the pain started in his right knee and then progressed to his right ankle, his left ankle, and his left knee over the span of a few days. He had went to his local clinic during that period and was given some analgesia. But when the pain began to progressively worsen, he presented to his local hospital ED. He reported no history of any chest pain, shortness of breath, abdominal pain, or diarrhea. He had no urethral discharge or skin rash reported, and he reported no history of any morning stiffness or any prior joint pain. With regards to his past medical history, he was previously healthy and not known to care. He worked as a security guard. He reported no alcohol use or the use of any substances or cigarettes, and he was in a monogamous relationship with one partner. He had no allergies, and his family history was unremarkable. And I'll stop there.
Zakaria, this is a very intriguing aliquot, in large part because you've answered Reza's first question, which is, has there been any trauma? And the answer is yes. But then when you dive into the details of the case, you realize that the trauma and the overlap of the syndrome is questionable. That's because the patient identifies the trauma to be directed at one part, and yet he is having symptoms in others. And so the question becomes, is the trauma related at all? And could it be related by the fact that sometimes when we fall, we have what are called distracting injuries? It's common in the trauma literature to have not noticed that you've broken your hand because simultaneously you've broken your neck. And so that's a question that I think you'd be answering. And I think you'd be trying to see on exam if there are skin markers of trauma, like abrasions on the sites that he is hurting otherwise. So I think right now the question and the relationship of trauma to this event should be questioned. And on exam, you might see the clues as to whether you can connect the trauma to all the joints, connect the trauma only to the right knee, or actually disassociate the trauma from the current syndrome. And I think that's going to be a key part of our analysis. Right now, it's hard to make progress on that without answering that question on exam. So I'll just leave it at B, that I think that the progress that you've told us, and the HBI tells us fundamentally to lean into Prof. Rez's advice on the exam, to try to understand the syndrome better in that space, and to be open to the trauma being mildly connected, deeply connected, or unconnected to the current syndrome, which appears to be focused on the joints since there's nothing else going on so far. I appreciate both the understanding that this is not related to any other symptom currently or even in the past, as you've done a really good review of systems to help articulate what kinds of issues might affect joints in this manner. But now I'm really, really curious to see what the exam is like to help us understand the foreground, and then to go back in time and see if we can make any inferences from the medical history. That's sort of my broad strokes reflection to this aliquot. I'm really curious if Prof. Rez latched on to anything I might have missed, or go for it.
No, that sounds wonderful.
Wonderful. So onto the third aliquot, which was his physical exam. His vitals were a temperature of 39.1 degrees Celsius. His blood pressure was 178 over 114, and his pulse was 127. When you looked at him, you noted a male in his 50s with a BMI of approximately 35, who appeared to be in significant pain. With regards to his general exam, he had no conjunctival icterus or pallor, no lymphadenopathy noted, nor were any pharyngeal exudates seen. On his cardiovascular exam, he had prominent pulses, including a very prominent pulse in his neck. When you looked at it further, you see that there was a very sharp upstroke and it collapsed immediately afterwards. His JVP was not raised and his apex was not displaced. He had an S1 and S2. And when my senior examined him after I had, because this was in medical school, he felt that the patient may have had a murmur, but must admit that when I listened to it, I could not appreciate one. His respiratory exam was normal, as well as his abdominal exam. On his neurological exam, he was alert and oriented ×3, and he had normal tone and power in his upper extremities, but it was impossible to do a full neurological exam on his lower extremities due to the severe pain that he was experiencing. On his musculoskeletal exam, he had diffusely swollen, warm, and tender knees and ankles bilaterally that was worse in the right knee. No skin abrasions or any rash were noted specifically on the right knee. When my senior examined him again afterwards, he also felt that the patient may have had mild synovitis of his PIPs bilaterally without DIP involvement. He had no other evidence of any tenosynovitis, and no gouty tophi were noted, and no other skin rash was noted on physical exam. And I'll stop there.
You know, Zachariah, what I love so much about your presentation of this aliquot is how honest you are with our limitations to perform a physical exam. And I'll just share a quick story with you. Recently, my team admitted someone with 1 week of shortness of breath. And this was literally a few days after Charmaine and Jack had discussed a case of severe aortic stenosis. But we admitted this patient, we didn't have a prior echo that was accessible. And I listened to his heart. There was zero murmur. Like I couldn't auscultate a murmur. The intern had accessed records from another facility and found that the patient had moderate aortic stenosis. So in my attending attestation, I said, we're just gonna wait for the echo and go from there. But I could tell that there was jugular venous distension. I could see fluid in chest x-ray in the lungs. And so I said, it's heart failure. But the intern went on to include in their DDX, could the aortic stenosis have worsened? And is this severe aortic stenosis? We got the echo and the valve area was less than 0.4, confirming her hypothesis of progressive aortic stenosis. So even getting the echo and seeing that very small valve area, I went and I re-examined it and I still couldn't hear the murmur. So it just tells you we are limited. The smaller the valve area, the harder it might be actually to detect the murmur because you're not getting as much turbulent blood flow. But why don't I get back to discussing this case and leave that case for another VMR? So for this case, I'll just share my brief thoughts and then hand the mic to Robbie to further comment. I think a few things happen here. One is this fever. So no longer are we dealing with just an articular process. We're getting clues of a systemic process. There is underlying inflammation. So we went from just one knee being involved to multiple joints with inflammation. So now I'm activating our framework for inflammation, infection, malignancy, autoimmune. Then the other thing that's really important about this exam, beyond the joint exam, is the neck exam. I think that's like so incredible that you guys were able to detect that, just seeing some abnormalities. And what it seems like you're describing is a carotid pulse, not a jugular pulse. And if you're seeing a very brisk upstroke and then a collapse, that's telling you that in diastole, something's happening, that the blood is just falling down immediately, the column of blood. And usually that's suggestive of aortic regurgitation, meaning you have a lot of volume in the left ventricle. So boom, you go, it goes up. But then if the valve is leaking, it drops quickly. The other things you can look for aortic regurgitation is, and we had this with Arsalan, one of the founding members of CP Solvers, is the water hammer pulse. Like literally you can start seeing the brachial pulse pulsating. And then it was at Hopkins, he went and he put his finger on the patient's nail and saw Quincke's pulse. And that's again, another marker of severe aortic regurgitation. And then it's not easy to auscultate a diastolic murmur, but if you look, you shouldn't close your eyes. Closing your eyes doesn't make you hear any better. Just look at the neck. And if you're hearing the murmur as that pulse is dropping, then you know it's diastole. So now we have fever, we have murmur, and we have multiple joints. What rises to the DDX is stuff like endocarditis. You have to, this is probably like the thing you don't want to miss is endocarditis. And anytime you have a diastolic murmur, it's a pathologic murmur. So already I'm thinking, do I need to salvage that valve? Now, because the joints are involved, you can ask the question, are there any processes that can affect the joint and the aorta? So not just the valve, but the aorta or the valve. And this is referring to aortopathy or acute aortic syndromes. And the way you can make those links, just to give you an example, you can have lupus, and then you can have that affect the large vessel, causing separation of that tricuspid aortic valve, leading to regurgitation. You can have lupus, and then you can have Limp-and-Sachs endocarditis, and then have regurgitation. So I think the most sinister hypothesis here is infectious. So you're going to get 3 blood cultures before you give any antibiotics. You're going to get an echocardiogram. You're probably going to start treating for endocarditis. And then you're going to look and see, are you dealing with an aortic pathology that's leading maybe an aortic dilation, aortic dissection, or are you dealing with a valvular pathology like a vegetation? I think that will help guide the next step. So once, if infection is ruled out, then you can start prioritizing other causes of oligo or polyarthritis and valve or aortic pathology, including stuff like lupus, stuff like spondyloarthropathies that can affect the aortic valve and such. But I'd love to hear from Robbie too, to see what his thoughts are.
Oh, Professor, I have nothing to add to those thoughts. I'm about the heart stuff. Maybe I can examine the reflect on the knee, on the arthritis findings here, and layer them in, because I think that we're in a little bit of a tricky situation about like labeling the arthritis as accurately as we're able to label the cardiac issue here, and that's because it's still open for question whether this is an oligoarthritis or a polyarthritis, and I'll tell you why it matters. If we just take license to focus on what Prof. Rez is encouraging us to focus on initially, which is infection, and then, of course, autoimmune disease. If you take that consideration of infection and then you layer it upon the possible arthritis, you'll realize that in every category of arthritis, mono, oligo, or poly, infections are a consideration. But as soon as you zoom in, you realize that the landscape is a little bit different depending on what kind of arthritis you label the patient as having. Monoarthritis, pyogenic bacteria are the leading considerations, as are rarely granulomatous infections. Oligoarthritis is the same as mono. Pyogenic infections, often staph and strep, but importantly, Neisseria gonorrhea is another pyogenic infection, and the same old differential. Unusual atypical granulomatous infections, and then, of course, spirochetes, namely Lyme disease. That's the list for mono and oligo. What's the list for poly? Very, very different. The classic infection associated with true polyarthritis are viral infections, and so that with parvovirus B19 being there. And so I'm really trying to understand and examine these joints carefully, because I think they matter. If we label the joints as symmetric, over 6 joints symmetrically involved, it suddenly becomes a little bit less likely that this person has a pyogenic bacterial infection or an atypical granulomatous infections, because those don't tend to cause pure symmetry in many different joints. So now I'm looking at this closely and I'm saying, what do I call this? Knees, ankles, right, greater and left, PIPs, and I'm struggling to know what to call it. But I think this goes to show you how expertise, say a rheumatologist were to examine this person, we're talking about like nuances of exam, right? From even the internal medicine attending to the rheumatologist, as you outlined, Zachariah, so authentically, the difference between you and your senior, there's going to be a very big difference between me and the rheumatologist, but I tell you why it matters now. If the rheumatologist walks in this room and says, hey, this is a symmetric polyarthritis, I think we would still work up all the infections because they're no miss, but I think we'd be thinking a step ahead and saying, that's weird for these infections. What can I do? Assuming that they'll come back negative if they do. So I'm intrigued to see where that dimension goes because it really changes the calculus. So what's the learning point in terms of the arthritis category, to summarize? Every category of arthritis features an infection. Oligo and mono feature the same kinds of infections: pyogenic bacterial infections, spirochetes, namely Lyme, and then granulomatous infections. Polyarthritis tends to be more viral, with the two leading considerations being parvovirus locally, parvovirus globally, and then chikungunya in certain geographic locations. Alrighty, Zachariah, I'm really intrigued. Tell us more, please.
Wonderful. That was absolutely amazing. And onto the initial labs as well as some imaging. Would it be possible to share a picture after the labs? With regards to his full blood count, his white cell count was 15 with no differential available. His HB was 12.5. His creatinine was 0.98 with no previous baseline. His urea was 5.7, which was normal. His sodium was 132, and his potassium was 5. His liver enzyme showed a mildly elevated ALT of 48, but everything else was normal. His CRP was 180. His HIV test was negative, as well as a test for syphilis. His rheumatoid factor was 34, which was borderline elevated, and an anti-CCP antibody was negative. His ESR was 20, and I'd like to share an image, please. I also have to share this image with the caveat that I have absolutely no idea how to interpret it, so I will definitely need help there, please.
I also have zero idea, Robbie. I had on YouTube because you were speaking on the site. I have like 2 minutes, but I'll just take a crack. Like what I'm seeing, unless it's like artifact of the actual image, when I'm looking at the right knee, it almost looks like those joints are fused, like there's no cartilage there because I'm seeing white on white, but I don't know if that's like the modality of the imaging. When I look at the left knee, you're seeing the femur, and looking at that joint space, maybe there's osteophytes or hooks in between, but this is coming from someone who really doesn't look at any x-rays. So I'm not sure what to make of that. Yeah, but maybe you look for chondrocalcinosis and stuff like that, but that's as far as I can take it, my friend, for someone who looks at one knee x-ray per year.
Wonderful. Well, that's definitely better than what I had. So,
Ooh, Zachariah, I think you were muted, just like me.
sorry.
No problem.
Before I continue, are there any other labs that you would like?
No, I think maybe what we can do while Prof Rice is away for a few minutes. That's my mom calling. Is we go into a few breakout rooms and just discuss the data so far. I think that would be really interesting because we have certainly a lot to work with. So I'm just going to make a few breakout rooms. If you are unable to join, don't worry about it. But if you are, I think it'd be a really good time to discuss what you might do next and what other labs you would get. So we'll see you all in a few minutes. Here we go. Alrighty, cool. A smooth transition. Nothing happened in the last 6 or 7 minutes at all. Zachariah, it's really, really telling. I'll just keep the theme going on reflecting on the analysis of infection and the kind of infection. And I think that I'll just tackle the CBC maybe to answer that question, and I'll leave any other clues for Prof Rest to reflect on, which is when we have that spectrum of infections in front of us, which is pyogenic infections, granulomatous infections, and then viral infections. I think the leukocytosis here, if neutrophilic, which it likely is, since it's hard to invoke lymphocytes or eosinophils in the syndrome, I think that pushes us more towards the former category of pyogenic infections, granulomatous infections, and spirochetes. So if the CBC had come back completely flat, completely normal, I'd be more intrigued and look back at the joints and wonder, hey, is this viral? Therefore, is this polyarthritis? So I think that's what the CBC helps with. It helps move towards the little bit more aggressive infections. What do you think of the other labs or the white count, Prof. Rez?
No, I love that. I'm like so eager to see what this echo shows, honestly. That being said, did we ever make a figure for RF positive? Somewhere in the back of my mind, I think we have one on RLR, but maybe I'm mistaken. But anyways, we thought a lot about it. I just wanted to make the point that RF is one of like the most non-specific antibodies. It's an antibody to an immunoglobulin, and anything that revs up the immune system might result in a positive RF. But there's like a few diagnoses that you have to consider when you see this, especially when you have someone who's inflamed, and especially if they have a history of Hep C. So complement levels can be helpful here, because if you have a disconnect between C4 and C3, and you have a positive RF, you have to think about cryoglobulonemic vasculitis. So all I want to say is RF is not specific to rheumatoid arthritis. And rheumatoid arthritis is really a clinical diagnosis because so many of those patients are seronegative. This would be an odd manifestation, of rheumatoid arthritis. But Robbie, initially when he was presenting this case, I started to think of like palindromic rheumatism, because you're getting one joint, the following joint. But in reality, it's like, I don't know if that's a reflection of how this patient is coming to attention, meaning they came earlier versus others who wait until stuff becomes some, because even symmetric processes may start one side and then become symmetric. But I think the fact that it did go from joint to joint, you have to entertain that palindrome. And what that does for me is, in addition to stuff like gonococcal arthritis that you mentioned, it puts in that category of rheumatoid arthritis, can be palindromic, polymyalgia rheumatica can have, but it does potentially give the flavor of an autoimmune. As you were mentioning, if you have a lot of joints involved, then you're getting away from, infectious etiologies. And anyways, that term is a really cool term, palindromic rheumatism. Take a look at it. I learned that from LT, and it might have some value, but
it's the second best palindrome. Can I just make a note of the fact that none of us are talking about cancer here? It's just such a profound reflection about arthritis, which is even though you can have many cool paraneoplastic conversations about arthritis, the tension that rheumatologists face all the time is it infectious or is it their disease? Is it infectious or is it their disease? And then only after that do we think about cancer. So arthritis is, notice that the dance is all about infection and autoimmune disease, and who knows, maybe this will be a cancer knowing Zakaria, but that tends to take up space much later on. All right, Zakaria, tell us more, please.
Wonderful. There'll be two more added parts. The first one is just a few additional guests. 2 blood cultures were both negative. A uric acid was 8 milligrams per deciliter, which was borderline elevated. It was actually slightly elevated. A transthoracic echocardiogram showed good LV function and no evidence of endocarditis or any valvular disease. Arthrocentesis of both knees were negative for crystals. The gram stain was negative. The culture was negative. A TB PCR was negative. Unfortunately, no cell count was available, but on microscopy, an extremely dense inflammatory infiltrate was seen, consisting almost entirely of segmented neutrophils. No malignant cells were seen either. And I'll stop there.
Robbie, is it your turn or is it my turn? Oh, it's my turn.
I started with the white last time, so it's all you.
The first thing I want to do here is just show you guys that, in fact, my memory, I'm not demented yet. Like, we did make a figure for RF positivity, and it's just to show you that 5% of the population will have RF that's positive, and in 1/3 of patients with RA, it's negative. Look at this. RF is more likely to be positive mixed cryo than RA, and more likely to be positive in Sjogren. So a lot of time, people who are going to diagnose RA, they really want to roll out Sjogren syndrome. Okay, so that being said, Zachary, that's so interesting with regard to the echocardiogram. And you would be curious if they got a picture of like the ascending aorta, because, it's the positive exam findings have a high predictive value. So I'm still trying to understand why there was this brisk upstroke and then complete collapse, and why your learner auscultated a murmur. So I might ask the cardiologist if they were able to see the ascending aorta, or that might actually just prompt me to get a CAT scan to better evaluate the aorta. Because again, positive findings I take very serious on physical exam, while negative findings don't necessarily rule out a pathology. I think the blood cultures being negative lessens the likelihood of like your typical bacterial endocarditis by like common organisms, especially if the cultures were collected before antibiotics. Sometimes they aren't. And so antibiotics end up being the most common cause of culture negative endocarditis. I would love to hear Robbie's interpretation of this arthrocentesis, but I'll take a crack at it. And for me, the lack of crystals doesn't necessarily rule out crystalline disease, but it makes it less likely, because all of these tests are not perfect, and it's hard to actually see crystals. And we've had, just based on the base rate, like crystalline disease can manifest in so many ways. But I think one thing you can really conclude from this arthrocentesis, it's that it's extremely an inflamed joint, extremely inflamed. That's really helpful. So like whenever you're looking at a joint, you break it down to non-inflammatory and inflammatory. Though we already knew we were probably dealing with an inflammatory process because we have multiple joints and we have this background of fever. The more segmented neutrophils you have, the more you have to be concerned for an infectious etiology. The more you have to be concerned for an infectious etiology. And the gram stain sensitivity to rule out infection in the joint space is not that great. And I don't know, Zachariah, do you have an absolute number on the white count in the joint, or do you just know that it was like a lot of neutrophils?
Unfortunately, no cell count was requested, so we just had that microscopy.
Got it. Yeah, so that's helpful. And the reason I ask that is because once you start getting north of like 100,000, then you really got to take this very serious, that maybe there's like a pyogenic infection. And the common infections are staph, strep, and then gonorrhea, as Robbie had mentioned. So where do we go from here? I think in addition to maintaining infection on the DDX as we're awaiting these cultures, I would have this patient absolutely on antibiotics. I would consider imaging the aorta. I would send an ANA because we are getting a flavor of potential autoimmune pathology. And I would consider even like maybe broadening, depending on the, like Robbie said, the number of joints, to entertain the group of spondyloarthritis, because I am worried about that aorta. But Robbie, anything that you can grasp based on this densely, infiltrate of neutrophils?
Yeah, Prof. Rez, I think that what's happened for me, big picture, is that we've made progress on the joint aspect. We've now proven peripherally it's neutrophilic, and intra-articularly it's neutrophilic. And so I think that is a thread to follow. To be honest, I think that I don't have anything to add to your reflections about that. I think they're spot on. So what I'm trying to do is to say, well, how can we synthesize the physical exam findings centered around the aortic valve with the echocardiographic findings? And I love how much you're pointing us to the idea that they could be unified to the aorta, and the aorta is linked to arthritis through many ways, especially the spondyloarthropathies. And I think that's going to be a really important thread to tug on. Parallel to that is going back and interpreting what we saw on physical exam, which is that you essentially saw a hyperdynamic LV ejection causing the pulsation to go up and then go down again. And based on a outstanding tutorial from Andre Mansour, who taught us that the findings of chronic AI can be essentially identical. And I'll try to find that and share that with you before the end of the MR here in the chat, that the findings of aortic regurgitation can be identical to the findings of high output cardiac failure. So I'll share with you a visual that I'm trying to see if I can use to help us understand this case, and go back to the objective finding we have that this patient is exhibiting a high output state based on exam. And the question is it a pathologic high output to compensate for heart failure, either chronic AI or high output CHF? Or is it a physiological state that is as a result of 5 things you see here? And I'm wondering if in parallel to pursuing the aorta hypothesis, which would be life-threatening and probably my lead concern, is in parallel to evaluate the possibility that the cardiac findings are merely a fingerprint of the severity of the neutrophilic disease we see in the blood and in the joints. And I think working those 2 things up sequentially, first by wondering about the aorta and doing a good pulse exam, and then if that is exonerated with high quality tests such as imaging, moving on to saying, I think the heart is just really faking us out here. And so that's the thread that I'm exploring. I have nothing to add to your analysis of the joint. I think the key questions are, is this an occult infection or is this a crystalline disease? And then finally, if we find link, especially to the aorta, is this a spondyloarthropathy type condition? The next step I would emphasize, in addition to everything that Prof. Rez mentioned, is to make sure that you realize the sensitivity of disseminated gonorrhea in terms of the joint is very low. The best test for that condition is to swab the mucosal surfaces, including the pharynx, the rectum, and basically any mucosal surface that's in sexual contact. All righty, Mike, to you, Zachary. A really, really intriguing case. It's so hard to know what the problem is. So utterly clueless what the solution could be.
Well, the solution was something you've often emphasized the importance of, which was he was transferred to the medical ward, and some of my seniors who were part of the medicine team, I was working in the ED, went to see him again and sat down with him in a more private place, and they took a further history from him. He then endorsed subsequently that a similar episode of joint pain had occurred a few years prior that had self-resolved. He also reported a long history of intermittent severe alcohol consumption on weekends, which had occurred prior to the episode. And he was admitted to the ward, started on multiple medications, and he proceeded to make an almost remarkable recovery within 24 hours. And the final diagnosis, I think I can stop there if you want to discuss further.
I just sort of start out reflections. I think that if you incorporate the rapid improvement, even without knowing the medications, and you just know the patient got medications and got much better, I think you'd really emphasize going back to the anchors that Prof. Rez said is infection versus crystal, and I think you'd prioritize crystal. And I think the question to wonder is, what are the crystalline diseases, the main ones, and which ones are the patients at risk for? And so honestly, I think that the true expert in this condition, having read a lot about it recently, is Prof. Rez. So I'll pass the mic to you to see how you're taking it through. But I think that the rapid improvement would have me at least lean against infection, which even if treated well with antibiotics, often doesn't get better in 24 hours. So yes, as John just said, the gout master, the mic to you, my friend.
Yeah, thanks so much, Raleigh. I do want to acknowledge the thing you said about high output failure. It makes me wonder whether this patient has multiple diagnoses. For example, could they have thiamine deficiency leading to high output failure with the brisk pulse? I was curious to know from you, in that category of high output failure, is there any overlap between that DDX and joint and inflammation? Because I think of like thyrotoxicosis, that can cause high output failure and inflammation, but not so much joint pathology. There's Paget's disease, but I don't think of that as intra-articular. There's anemia But is there anything else on that list that might unify just as a way to exercise that hypothesis?
Yeah, Profres, when I ran through that, when I was when you were talking, when I was thinking through that, I couldn't find an overlap. And then I looked at his analysis again, and I don't think it would be a stretch to come to the conclusion that I think it is demonstrable to come to the conclusion that he has a high output state. He's tachycardic, hypertensive, and is hyperdynamic. I think there is no evidence of the failure part, which is why my leading hypothesis would be that he is having robust systemic inflammation, and that there is the cardiac manifestations are compensatory to the joint issue and leave no bearing of disease for two reasons. One is I don't think that he's demonstrating evidence of the failure part of high output failure with dyspnea, orthopnea, elevated JBD, lower extremity edema. And as you just pointed out, I struggle to find an overlap in the world of high output cardiac failure and joint disease without having to really bend the rules of things. So yeah, that's why I feel like my mind is almost, maybe prematurely, but just authentically concluded that the heart is a massive distractor here. And my mind is locked in on the joints. And I'm curious, I think you would know that for sure if we asked Zakaria, when we say he got better with the medications, and we treated the inflammation, did his heart aspect get better? That would help us be more confident about that. But that's where my head is at.
I absolutely love that. And I love how honest we've been with saying that, look, you really got to rule out, do not miss that. You have to rule out aortic regurg. You have to rule out aortopathy, even though you have an alternative explanation, just being inflammation and sepsis causing the high output failure. And this is also why when you do the echo and someone has a high output state, you might get really high pulmonary pressures. And so be cautious with interpreting those echoes when someone has anemia or a high output state. But ultimately, Zakaria, I think what this comes down to is this right here. And we have a video on RLR. It's 13 minutes of us blabbering about gout. And dude, it's been a while since I've been in front of that whiteboard. I miss it. I've been recording videos in my office. It's just not the same. But this is our figure. And if you go and look at the risk factors, obesity is one, being male is one, aging population, and hyperuricemia. And alcohol has purines. Purines increase uric acid. So alcohol is a risk factor for gout. And it's usually mono more than polyarticular. And it's rapid. Look at that. It peaks at 24 hours. And ultimately, we're back in this category, like where we were initially, honestly, for like monoarticular, ruling out like the fracture, the infection, and then its cousin, crystalline disease. So you could actually do a dual, if you have that capability at your institution, this would give you the answer, most likely, a dual energy CT scan. It's very good. But I just want to say that I think you have to just go cautiously here. Like, remember the arthrocentesis showed no crystals for Zakaria, just a dense infiltrate of neutrophils. So would I feel comfortable giving this patient prednisone? No, I wouldn't. To be honest, as an internist, I wouldn't. But I'm just curious if Robbie has anything to add, and then like just hearing from Zakaria how they tiptoed that line of like when they felt comfortable saying, hey, this is not infectious, and we're going to give this patient, I would give this patient thiamine, by the way. I absolutely would. Like if you're drinking alcohol every day, you're at risk of micronutrient deficiencies, and that can add to this high output state. But Robbie, anything else to comment on? I just don't know when I would feel, I just wouldn't feel comfortable being like, hey, this is polyarticular gout. Let me give steroids. I have fever, I have joint pain, the patient's inflamed. I don't know.
Yeah, I think these cases are real life tension, and nobody really knows. Nobody really knows for like a day or two. And, we admit a lot of these patients, we watch their cultures, and then we just like cross our fingers and hope, because The tests for infections are very flawed. Even culture only has 70% sensitivity. And the tests for crystalline, as you're seeing, are very, very flawed. So this is an age-old dilemma. And you'll see that when you don't know, you just actually simultaneously treat for both. And then you try to figure out what happened in retrospect. And many, many patients get empiric courses for septic arthritis for a long period of time. I'm just giggling, Professor, because I just hear my boss, Jody Garber, in my mind, because he says it's not gout. Don't call it gout. Call it gouch. And which is the ouch. And I'm just going back to the chief concern about excruciating joint pain and how I'm just giggling that that's probably what he would say in my ear if he were to saw this patient, like, oh, look, this might be gouch. And yeah, it hurts like heck. I think that I would be much more comfortable to render this diagnosis of gout if the patient had monoarticular disease without a fever. And so I think the question is, the question in real life that's faced, I would tell you how this probably would go down at my institution. The patient would get admitted, which we already learned. Most patients with gout don't get admitted, don't even come close to getting admitted. And then they get vancomycin and ceftriaxone. We do wait for the blood cultures, wait for the synovial cultures. And then if nothing grows and the patient is not better by day 2 or day 3, then the rheumatologists are like, okay, you know what? Let's pull the trigger. And then which trigger? There are 3 triggers to pull. The patient has, you can give NSAIDs, you can give prednisone, and then you can give colchicine, but it's often too late to give colchicine by day 2 or day 3. So you can give anakinra. And I will tell you, depending on how confident the rheumatologist is, if they're super confident, they'll give anakinra. If they're like mildly confident but cautious, they'll give prednisone. And if they're very, very, very cautious and they're worried about infection, but they're getting close, they'll give NSAIDs. And that's how it plays out. Maybe once every month, we have a case exactly like this. So I'm really, really curious, Zakaria, what your practice pattern is, because you see it's very, very variable. And all of you should know there is no perfect test for any of these 2 conditions. We often treat for the morbid one. And then as time goes on, and if the patient isn't getting better, we then have a box of anti-crystal medications, which are variably immunosuppressive, NSAIDs, prednisone, anakinra. The more confident we are it's a crystalline, we'll go for the anakinra, and the more unsure we are, we'll go for the NSAIDs and see if the patient gets better. I'm really curious how the dice rolled in this case.
And just to add to that, just anakinra is an IL-1 blocker, and IL-1 is the main interleukin in gout pathophysiology. So it just is beautiful. Once you understand the pathophysiology, then the medicate, that's like very targeted therapy towards the arm of inflammation precipitated by crystalline disease.
Spoken by the master of gout. All right. Zakaria, tell us more, please.
Absolutely amazing. He was admitted to the ward, started on antibiotics, colchicine and NSAIDs. And due to his remarkable recovery within 24 hours, the antibiotics were stopped and he was given the diagnosis of severe atypical hyperinflammatory gout. And looking now, almost 3 years later, I checked online on our hospital records. He has never been admitted again to the hospital. He continues to have a slightly raised uric acid, but has never required any admission for any of the sort of more serious pathologies we were considering.
Zakaria, I have to jump in here because I'm not sure. I know you have binged every VMR. I'm forgetting to remember if this was an RLR VMR or another one, but we had a case where Dr. Ori Lieberman, who is now a neurologist at UCSF, presented a case of distributive shock from gout, and he proved it to like a very high level. Were you there for that, Zakaria, or do you remember that case?
So I can actually tell you. So firstly, whenever I try to spread clinical problem solvers propaganda to my friends, that's the exact case I share with them. It's actually my favorite VMR ever. And wow. I think sort of coincidentally, that case happened sort of round about the time where I saw this patient. So after I listened to that case, I had this patient and he had such severe joint pain. And it was just in the back of my mind, could this be another weird atypical manifestation of gout? And yeah.
Well, I have to hop off because I'm a little bit late for round, so I'll pass the mic to Prof. Raz in a second. But I really just wanted to sincerely thank you, Zakaria. I think every time you've been here, it's always such a treat. to get to dissect your really, really intriguing cases. And you set us up for such a rich conversation. It would have been so easy for you to not bring up the hard stuff because you just want to streamline the conversation, but you took us to where you were and the tension you were feeling and the fact that endocarditis was obviously on your mind with the 2 blood cultures and the echo that you obtained. And letting us live through that tension was really, really authentic. And I also just love how you are so vulnerable and you're saying that I didn't see this, but my senior saw it. And it's the kind of stuff that we hope to role model. So thank you to you for really passing on what we love to pass on. So big gratitude to all of you.
No, though the senior led us astray. If we didn't see it, it would have been better.
Friends, I'll make you the host because I gotta make it to on time. Well, I'm sorry I'll miss your teaching. Thanks, guys.
Take care, Ravi. Yeah, Zachary, I also just wanted to say, like, I never thought about like the DDX for aortic regurg. So that was like a great teaching moment for me. And I think for me, this is a bit practice changing in that someone who can tolerate NSAIDs and colchicine, just start it early. Like, why wait? You know, if you're tiptoeing between these 2 possible diagnoses, like the kidney function's okay, they don't have any history of ulcer. So I think empower me to start NSAIDs maybe earlier, as opposed to waiting, you know, multiple days to rule out him, because the patient's in such severe pain. So I think that for me is practice changing. Thank you so much, Zachariah. Why don't we pass the mic to Amol to take us home?
Thank you so much. And thank you for this a different case again with the same complaint of joint pain. So 2 weeks back, I think we had a VMR which had joint pain, and there we learned that joint pain is not necessarily joints problem. It could be diffuse tendon, ligament, or bursal problem. And whenever more joints are involved, we more get inclined towards a real joint problem. So again, we had today a case of right knee pain, which classified as monoarthritis as of the first aliquot. And we thought that it could be intra-articular or periarticular, again, in periarticular ligament or tendon, which has ruptured, causing the excruciating pain which the patient had presented with. So we need to rule out any history of trauma or injury to the knee, and it would be important to examine the knee as well, and checking the range of motion, which gives us more clues towards the diagnosis. And when we think about monoarthritis, our main differentials are crystalline disease. And infection is common to all 3 buckets of oligoarthritis, monoarthritis, and polyarthritis. Then we saw in the next aliquot that some other joints were involved as well. And we again say that the involvement of more than one joint indicates that it is more a joint problem, not a bursal or ligament problem. And presence of trauma in the patient need to be understood if it has affected all the joints or are there distracting injuries. Then we saw in the cardiovascular examination some criteria which pointed towards aortic regurgitation, and we discussed things like Waterhammer pulse and Quincy's pulse as well. Then the patient had fever, murmur, and joint pain. So we thought of disease which could affect the valve or the aorta. Valve in the form of infective endocarditis, or aorta, or maybe acute aortic syndromes, aortopathy. So we thought of taking 3 blood cultures followed by antibiotics and an echocardiogram to confirm our diagnosis. And we also realized that lupus and spondyloarthropathy can also affect aorta. Then we discussed about arthritis and its 3 types, that infections are common to all the 3 types. Monoarthritis and oligoarthritis have mostly pyogenic bacterial infections and spirochete infections. Polyarthritis has viral infections, parvovirus B19, and chikungunya. Then we saw in the labs the patient had leukocytosis, which made us move towards the oligoarthritis category of pyogenic bacterial infections more than the viral infection category. Then we also discussed that rheumatoid factor is a very non-specific antibody, and the few diagnoses which we need to consider when we have RF positivity is mixed cryoglobulinemia. For that, we can check the complement levels. And also we have to rule out Sjogren's syndrome if the symptoms are present. And we also realized that RF is negative in 1/3 of patients with rheumatoid arthritis. And then we studied a new term today, that is palindromic rheumatism, which is the form of inflammatory arthritis in which joint pain and inflammation, they come and go. And then in the last aliquot, we saw that the patient's symptoms, they recovered within 24 hours, which made us get inclined more towards if it was crystalline, because we were thinking if it's crystalline or is it infectious. So infections don't resolve so easily. So then we thought about it could be crystalline. And regarding the tachycardia, hypertension, and hyperdynamic component of this patient, we initially thought it could be high output heart failure, but there were no heart failure symptoms present. So we thought that it could be a cardiac manifestation of the pain which the patient is having, maybe the heart response due to robust infection. And we realized that the treatment for this patient would be thiamine for sure, because this patient is alcoholic. And if we think that if it could be gout, then we can go for anakinra, which is IL-1 blocker. IL-1 is the main interleukin involved in the pathophysiology of gout. And the risk factors of gout would present, that is male, old age, and alcohol. And the gout, it presents as severe excruciating pain. That's what the patient presented with. So then the patient was diagnosed with severe atypical hyperinflammatory gout. Thank you so much for giving me an opportunity to present the teaching.
Amol, I can listen to you seriously all day. If you had your own podcast doing teaching play, it's like so good, so crisp. Thank you. I wish all of you a happy Friday and a peaceful weekend. Thank you all so much.
Thanks, everyone. Bye.
Bye.